All right, this is video number 3 about the suicide crisis protocol. And I just talked about the environmentally based risk factors. And the last risk factor I talked about was the availability of methods for suicide. Now we're moving on to the next slide and the next idea, which is behavioral risk factors. And for these, we break them down into the 3 categories of behavior that behaviorists look at. And there are risk factors within each one that predispose to suicide. So that emotions and thoughts and actions. So when it comes to emotions, the big problem is when emotions become intense and turbulent. And these typically will happen, for instance, with rapid cycling bipolar disorder, which is a high risk for suicide, and panic attacks, a cluster of panic attacks and panic disorder, and any other just severe emotion dysregulation, really of shame, of anxiety, of sadness, anything that becomes unbearable. So with those, you want to have short-term interventions if needed to help bring the emotions under control. And that, for instance, might even be a sort of brief psychopharmacology. It might be to help somebody with sleep right away with psychopharmacology. It might be with relaxation practices and other DBT practices for dealing with intense emotions, such as the TIP skills, the use of temperature, intense exercise, paired breathing, progressive muscle relaxation, things that come up in the distress tolerance module. Regarding cognition, there's 2 factors. One is the content and one's the process. The content is hopelessness, which correlates with suicide as much as any other factor I'm talking about. So intense or severe hopelessness is a really important factor, and you really want to become a hope-generating practitioner. You really have to counter hopelessness with everything you can. And the other one is the process of thinking in a rigid manner where your thinking is very black and white. And there you really need to work on helping people find the middle ground, helping people think more flexibly, more realistically, and not getting too trapped for too long in black and white thinking. If you put together black and white rigid thinking, along with intense emotional turmoil and hopelessness, this is a very deadly formula. There is another factor that I listed under cognition, which is if you have the thought that's persistent, that you perceive yourself as a burden to those in your life who matter. And if you see yourself as a burden, you're just more likely to suicide. So you need to fish that out and hear about it, validate that someone might feel that way and counter it. And opposed to suicide. And that's going to include suicidal behaviors themselves, including self-harming behaviors and other impulsive behaviors. Impulsivity begets impulsivity. And if there are other suicide risk factors in place, there's going to be more chance of suicide there. Another factor is the person's willingness to engage in risky, dangerous actions. There is a certain element of that predisposes to suicide that has to do with having desensitized yourself to doing things that are frightening, because killing yourself is a frightening thing to do, to go into the chasm, so to speak, and leap in whatever way you're doing it. And so if a person has already done some frightening acts, has made some previous attempts, or does other things, self-harm is to break a certain barrier. So if somebody is doing those things, you really want to know about that and to have that under discussion as well. The next slides are about different indicators and imminent risk factors for suicide. And the first of those slides is the direct indicators, which are kind of straightforward And there's data, fair amount of data for each of these. When there's a suicide ideation, with nothing else, the risk is not necessarily so high. But if there's suicide ideation accompanied by suicide threats to other people, there's statistically a higher chance that that's going to move on to suicide. If there's also suicide plans that are in place, now your risk has just gone up higher. And if somebody has prepared for suicide, if they've already taken necessary measures to get ready to have what's necessary in terms of methods and to make a specific plan on a specific day, now your risk has jumped up another notch. So there's ideation, then there's threats, there's plans, and there's preparations to implement plans, and each sort of correlates with a higher risk of suicide. So when you're doing your assessment with somebody, you want to be alert to those, all of those, and make note of those. Then I've got, the next slide is a list of indirect indicators of suicide. In other words, these are not ones that announce themselves as I'm suicidal, I'm going to kill myself, but they do go along with it. And so there are several of those. My way of remembering the direct indicators, the ones I just went over, are TIPP or TIP. My way of remembering the indirect indicators is what kind of subgroup are you within. So just knowing somebody's risk factors, if they have a lot of those risk factors, the risk is up. So you check on that if you don't already know. And the M for harm is medical problems, especially if somebody's seen a doctor recently and they have some concern about a medical condition that's been newly diagnosed or has advanced. Then there's DART. The D is disruptions, so losses, stressful events, other things that are disruptions in your life correlate with a higher risk of suicide. Abrupt, the A is for abrupt clinical change. So if you're, you are now presenting differently, and usually this means if you've had an abrupt decline in your presentation. In other words, things look worse now. You're more depressed, more anxious, more angry, more symptomatic in some way. For a long time, there's been a belief that an increase in your presentation and in the quality of your presentation, in other words, you've gotten better quickly, might correlate also with suicide because people have reported that it happens sometimes. It turns out in looking at that statistically, it doesn't really hold up. But it is true that somebody who is at that specific place of being hopelessly depressed in thought content and demoralized, and then acquiring new energy, that it might make it more possible for the person to engage in suicidal behaviors. The R is references to death. So these aren't ones where one's saying I'm going to kill myself, but it's making comments that indicate that somebody is sort of thinking directly or indirectly about their end of their lives in terms of we won't be coming back here anymore. I guess I'll give away these things. I won't need them anymore, etc., etc. Anything that could allude to I'm preparing to end it or to be done. And finally, the T in DART is therapy relationship problems. And there, the bigger problems that correlate with suicide are not the sort of, I'm in an intense, challenging relationship with my therapist. It's more indifference, like we really don't have much of a connection. So those are risk factors, indirect evidence of suicide risk. And finally, I have a list here of imminent risk factors. These are factors that I check on when I'm interacting with a patient in a suicide risk protocol, where these are things that really alert me, kind of like we could be within a few hours of a suicide attempt. So, and I have another acronym for remembering these, and the acronym is Impale, I-M-P-A-L-E. Right? So The I stands for 4 different things for me. Isolation. Is the patient more isolated now than usual? And then I realized, oh my God, this could happen in about 10 seconds. So I really worked with him and he was willing to, after a fair amount of discussion, and to actually get rid of the gun. P in Impale, precautions. This goes back to another one that I mentioned before. It has to do with if somebody has taken precautions in planning suicide so as not to be found out. So I specifically ask about that. Somebody says, well, I'm thinking of killing myself. I'm at home. I didn't go to work today. They think I'm out sick. Nobody's here. I say, but what about people showing up? Well, no, I've made sure this is a day when actually no deliveries. There's nothing comes to the house. The neighbors are not here right now. It's the middle of the afternoon. And so this person had been thinking about the various ways that something could interrupt his suicide plan and had taken precautions to make sure that wouldn't happen. So again, imminent risk of suicide. A in Impale, alcohol and drug abuse increases the risk of making a suicide attempt. Interestingly, if you look statistically, though this doesn't change how I intervene. If somebody has been using alcohol very much, they're actually less likely to carry through the act all the way, but they're more likely to try something. The other A is anhedonia. Somebody's just not experiencing any pleasure. There's just nothing out there that's worth living for. The L in Impale is a suicide letter or a suicide note. If somebody has written something, and I do ask about it in these circumstances, if somebody has written a letter, a note to someone about their suicide so as to be found, obviously they're thinking beyond the act of suicide. They're thinking of it as when it's complete, so-and-so is going to read a note. So that's a higher risk of suicide if they're doing that. And finally, the E in Impale is turbulent emotions. So again, as I mentioned before, panic and rapid cycling are important things to be considering. So this becomes like an inventory of factors, and I don't just run down the list when I'm talking to somebody. We're in a high intensity situation, and I find out I already know some things if I'm working with the client, and then I start asking other questions from these lists. Then I have a slide here about protective factors, which then completes your kind of risk factor assessment. There's also some factors that make it, that protect against suicide. And I'll just name them here. I think they'll be familiar to you. One is if I find out somebody does have hope for the future and plans for the future. If someone has some confidence about being able to change something in their life. If somebody is attached to life, they're still actually, it's worth living because of one thing or another. Someone has a sense of responsibility to some children or some pets or some other people, and therefore they're less likely to kill themselves. If somebody is socially supported or connected, if somebody has an attachment to their treatment provider, that also could be protective. If somebody is afraid of suicide, afraid of death, afraid of dying, and they really haven't gone through that desensitization process, it's just a little bit of a protective factor. If somebody fears the social disapproval of suicide, they just think this is not the right thing to do and they still care about that, that's protective. If they think that suicide is immoral and from the point of view of their religion is the wrong thing to do, these can be protective factors. Frequent attendance at religious services tends to be a protective factor. And finally, there are some people who are more motivated to overstate or to over-report their level of risk. And if you know that about them, then you can take the report of risk in a different light, and it might be a protective factor because they report risk before it gets to the end. Okay, we're done with this, and we're going to move on in the next video.